You know, there's an ancient Greek myth that has always stuck with me since I was a kid. It's the story of Prometheus. He steals fire from the gods, gives it to humanity, and as punishment, Zeus chains him to a rock.
It's a classic, for sure.
It is, but the specific punishment is the part that gets me. Every single day, an eagle comes down and eats his liver. And every night, the liver grows back, just so the torture can start all over again the next day.
It is a vivid, gruesome image. But, medically speaking, the Greeks were onto something incredibly profound.
Yes.
Oh, yeah. They pinned down the one organ in the human body that actually has that near mythological ability to regenerate.
Right. We talk about resilience in the body a lot, bones knitting back together after a break, skin closing up after a cut. But the liver is, it's in a league of its own.
Totally.
It is the absolute, undisputed champion of the comeback story. You can remove a massive percentage of it, literally cut away 2/3 of the organ, and it will essentially, clone itself back to functional size?
That's a great way to put it. It is a superpower. And it's a necessary one. Think about what the liver actually does. It's the body's filtration plant.
The main hub.
It takes a beating from toxins, from alcohol, from viruses, from metabolic byproducts. If it couldn't rebuild itself, humans probably wouldn't survive very long. It allows us to survive insults that would shut down the heart or the brain immediately.
It's basically Wolverine in organ form. But here is the nuance we need to explore today. Superpowers, well, they often have a shadow side.
And that shadow is exactly where we are living for this deep dive. We are looking at the central irony of liver pathology. Because what happens when that incredible capacity for regeneration is pushed too far?
Okay.
When the liver is injured not just once, but every single day for years or decades.
That's the question. We're asking what happens when the comeback story goes wrong.
Precisely. That is the question that defines hepatocellular carcinoma, or HCC. When the liver is chronically inflamed, constantly forced to regenerate in a hostile environment, that very process of healing begins to spiral out of control.
It's a tragic progression.
It really is. You have inflammation, you have fibrosis, which is just scarring, and you have this desperate, chaotic regeneration. And eventually, one of those regenerating nodules stops being part of the solution.
It stops following the blueprint.
It goes rogue.
Yeah.
It becomes malignant. And that leads us to the subject of today's deep dive, hepatocellular carcinoma.
This is a heavy hitter. We are basing this discussion on the Robbins hepatobiliary pathology concepts. For anyone who might not know, Robbins is essentially the Bible of pathology.
It really is.
If you want to understand the mechanism, the actual gears turning inside the disease, this is the source.
And our mission here is specific. We aren't just going to list symptoms like a medical dictionary. We want to unpack how chronic injury transforms into cancer.
Right.
We want to identify the usual suspects, the risk factors, and we want to visualize what is actually happening inside the body when this shift occurs.
And we should probably set the stage with the stakes here. HCC isn't just another cancer. It occupies a very specific, very difficult niche in medicine.
It does. Let's define it clearly first. Hepatocellular carcinoma is the malignant endpoint of chronic liver disease.
The end of the road.
It's a primary malignant tumor of the hepatocytes.
Hepatocytes being the main functional cells of the liver.
Yeah.
The workhorses.
Exactly, the little factories doing all the work. But what makes HCC truly formidable is the context in which it arises. In oncology, context is everything.
Reading through the notes, I saw this described as a double whammy.
That is the perfect way to put it. Think about breast cancer, colon cancer for a moment. Usually you have a tumor growing in an otherwise healthy organ.
Okay.
The surgeon can go in, cut it out, and the rest of the organ works fine. The patient might be otherwise healthy. But HCC is unique because it almost always arises on the background of a liver that is already failing.
So you have a tumor problem plus a liver failure problem simultaneously.
Which complicates everything. It complicates chemotherapy because the liver is the organ that metabolizes drugs. If the liver is broken, you can't process the chemo. It complicates surgery because you can't cut out a chunk of liver that is already barely functioning. You'll push the patient into total failure. And as the source material notes, it complicates survival because the tumor tends to spread early.
It feels like the walls are closing in from both sides. The cancer is attacking, and the fortress itself, the liver, is crumbling.
That is the grim reality. So if we want to understand the fruit, the cancer, we have to understand the soil it grows in. That seems to be the overarching theme here.
The soil and the seed. I love that analogy. In the context of hepatocellular carcinoma, the notes say the soil is almost always cirrhosis.
Correct. And we need to double-click on that term, cirrhosis. We hear it thrown around a lot in pop culture, usually in the context of alcoholism. But physiologically, we need to understand what that soil is actually made of.
It's not just damage, right? It's a specific kind of change.
It's a fundamental architectural restructuring of a liver. The normal liver is soft, spongy, and incredibly vascular. It allows blood to flow through it like water through a
A
filter.
very efficient system.
Incredibly. In cirrhosis, that soft tissue is replaced by tough, fibrous band scar tissue. This is collagen deposition.
So instead of a smooth highway system for blood and bile, you have a bumpy, scarred cobblestone road.
Exactly. And trapped in between those bands of scar tissue are islands of liver cells, hepatocytes, that are desperately trying to regenerate. We call those regenerative nodules. So the liver becomes this nodular, hard, shrunken rock.
And the link between this state cirrhosis and cancer is incredibly strong.
It is the strongest link we have. The vast, vast majority of HCC cases arise in cirrhotic livers. It leads to a fundamental clinical rule.
Yeah.
If you see cirrhosis in a patient, regardless of how they got it, you must automatically suspect HCC.
You have to be looking for it.
You have to be looking for it. You assume the soil is fertile for the seed.
Okay, so the soil is cirrhosis, but what poisons the soil? What are the drivers that lead to that cirrhotic state in the first place? The source material lists a few usual suspects.
We can categorize them. The global heavyweights are undoubtedly the viral causes. Chronic viral hepatitis, specifically hepatitis B and hepatitis C.
I think it's easy to group these together mentally, Hep B and C, like a package deal. But they work differently, don't they? Especially when it comes to cancer risk.
They do, and the distinction is vital. Let's start with hepatitis C. It's an RNA virus. It works largely by causing chronic inflammation. It's like a constant irritant, a splinter that never comes out. The immune system is constantly attacking the infected cells, killing them, and the liver's constantly trying to grow them back. That cycle of injury and repair, year after year, leads to scarring, which leads to cirrhosis.
So Hep C follows the standard road: inflammation, scarring, cirrhosis, then cancer.
Precisely. But then we have hepatitis B, and I noticed the notes had a specific warning, almost like a trap for students or clinicians regarding Hep B.
Yeah, let's talk about the trap, because we just established the rule that cirrhosis is the precursor, the soil.
However, hepatitis B is the exception to the rule.
How so?
Hepatitis B can cause hepatocellular carcinoma without established cirrhosis.
Wait, really? So you could have a liver that isn't fully scarred over, that isn't technically cirrhotic, and still get this cancer if you have Hep B?
Correct. And the reason lies in the biology of the virus itself. Hepatitis B is a DNA virus. Unlike Hep C, Hep B actually integrates its own viral DNA into the host's human DNA.
It splices itself into our genetic code.
It splices itself right in there. That sounds incredibly invasive.
It is. This integration can trigger mutations directly. We call it insertional mutagenesis. Imagine the virus inserting its DNA right next to an oncogene, a gene that controls cell growth, and accidentally turning it on, like a key breaking off in the ignition. So it skips a step. It doesn't need to wait for the scarring and the regeneration cycle to destroy the liver. It can hack the genetic code directly.
Exactly. That makes it more unpredictable. With Hep C or alcohol, you generally watch the liver get worse and worse, and then you worry about cancer. With Hep B, the cancer can arise even when the liver function looks relatively okay.
That is a scary but important distinction. It means if you have Hep B, you can't just be complacent because you don't have cirrhosis yet.
Right. The virus itself is oncogenic cancer causing, independent of the scarring.
Okay, moving on from viruses, we have to talk about lifestyle. The things we consume.
Alcoholic liver disease is the classic one. Chronic, heavy alcohol consumption is a massive driver of cirrhosis in the Western world.
And is that just because alcohol is toxic? Or is there more to it?
It is toxic, but
Right.
specifically, it's the metabolism of alcohol. When the liver breaks down alcohol, it produces a byproduct called acetaldehyde.
Acetaldehyde.
And acetaldehyde is nasty stuff. It directly damages DNA and proteins in the liver. It also triggers something called lipid peroxidation, which damages cell membranes. It basically cooks the cells from the inside out.
And doing that every day.
Leads to that relentless cycle of cell death and regeneration. The same story, just a different villain.
But there is another player rising in the ranks, isn't there? One that mirrors the global obesity epidemic.
Yes. NASH non-alcoholic steatohepatitis. This is linked to metabolic syndrome, obesity, type 2 diabetes, high cholesterol.
We often hear it called fatty liver, right? but that sounds a bit too simple.
It is too simple. People call it fatty liver, but the key part is steatohepatitis, which means fat plus inflammation.
Ah, okay.
It's not just having fat in the liver, it's the liver reacting to that fat as an injury. We are seeing a massive, massive rise in this. Just like with alcohol, that chronic inflammation leads to cirrhosis and eventually carcinoma. It's becoming one of the leading indications for liver transplants in the developed world.
So whether it's a virus, a bottle of whiskey, or metabolic issues from diet, the common denominator is that they all destroy the liver architecture over time.
They create that environment of chronic injury. They prepare the soil.
I want to pivot to something that felt a bit like a detective story in the notes. The environmental toxins. Specifically, aflatoxin. This sounds like something out of a sci-fi novel or a biological thriller.
It does, doesn't it? But it's very real. And it's a massive public health issue in certain parts of the world, particularly sub-Saharan Africa and parts of Southeast Asia.
So what is it exactly? A chemical.
Aflatoxin is a potent carcinogen produced by a fungus called Aspergillus. This fungus loves to grow on crops like corn, peanuts, and grains.
Particularly if they aren't stored correctly, in humid conditions.
Right. If they're stored in warm, humid conditions, which is common in those regions, the fungus grows and releases this toxin into the food supply. You can't see it, you can't taste it, but when you eat the contaminated food, the toxin is absorbed and goes straight to the liver.
And what does it do there? Is it just general damage like alcohol?
It's actually chillingly specific. Aflatoxin acts as a molecular sniper. It causes a very specific mutation of the p53 gene.
P53, we've talked about this in other contexts. That's the guardian of the genome, right? The tumor suppressor gene.
Correct. The p53 gene is responsible for spotting DNA damage and fixing it, or shutting the cell down, triggering suicide if it can't be fixed. It's the emergency brake for cancer.
And aflatoxin breaks it.
It breaks it in a very specific way. It causes a specific transversion at codon 249.
That is incredibly precise.
It is. It knocks out the safety brakes. So imagine a scenario where a person has hepatitis B, which is pushing the accelerator on cell growth, and they are also exposed to aflatoxin, which cuts the brake lines.
That's a recipe for disaster.
It creates a synergistic effect where the risk of cancer just skyrockets. It's a stark reminder that our environment, what we consume, even unknowingly, plays such a huge role in pathology.
We've touched on viruses, lifestyle, and environmental toxins. Briefly, what about the genetic lottery? The inherited drivers?
There are a few key metabolic diseases to know. These are less common than alcohol or Hep C, but crucial for understanding the mechanism. Hemochromatosis is the big one.
That's the iron overload disease.
Yes. It's a genetic condition where the body absorbs too much iron from the diet. The body has no efficient way to excrete excess iron, so it has to store it. And it stores it in the heart, the pancreas, and, of course, the liver.
And iron is toxic in high amounts. It's like rusting the organs from the inside.
Essentially, yes. Iron generates free radicals, highly reactive molecules, via something called the Fenton reaction. These free radicals tear apart DNA and lipid membranes, causing that same cycle of damage and regeneration.
So again, the same pattern.
And then you have Wilson disease, which is the same concept but with copper accumulation, and alpha-1 antitrypsin deficiency, where misfolded proteins build up in the liver cells and choke them from the inside.
So if we were to put this into an equation, a final common mechanism, how would you summarize it? Because we have all these different starting points: iron, copper, fat, viruses.
The source material synthesizes it beautifully. It doesn't matter if the match is lit by alcohol or a virus. The fire's the same. The equation is cirrhosis plus chronic injury plus regeneration equals dysplasia, which leads to carcinoma.
It's the constant repetition of injury and repair.
The inflammation is the fuel. The regeneration is the engine. And eventually, if you run that engine at the red line for 20 or 30 years, it blows.
Let's zoom in on that engine-blowing moment, the pathogenesis. We mentioned earlier that this is a story of regeneration gone wrong. How does the liver actually break?
To understand this, we have to look at the cycle of stress. There is a fundamental principle in oncology. Cancer arises where cells are forced to regenerate repeatedly under stress.
It's like, imagine a factory worker. If you ask them to build a complex machine once a week, they'll do a perfect job. If you force them to build 100 a day, every day, while the factory's on fire and the lights are flickering, mistakes will happen.
That is a surprisingly accurate analogy. Let's look at the step-by-step process. Step 1, hepatocytes, the liver cells, die due to the injury. Step 2, the body reacts with inflammation to clean up the mess. Step 3, the remaining hepatocytes try to regenerate to replace the dead ones.
Which is usually a good thing. That's the superpower.
Usually. But in this context, step 4 happens, fibrosis.
Yeah.
The scaffolding of the liver gets replaced by scar tissue. This distorts the architecture. The blood vessels get squeezed, the blood flow becomes abnormal, the environment becomes hypoxic, starved of oxygen.
So the cells are trying to rebuild the factory, but the ground is shaking, the supply lines are cut, and they can't breathe.
Exactly. And this leads to the tipping point. During this chaotic, frantic regeneration, genetic and epigenetic changes start to accumulate. The cells are dividing so fast under such bad conditions that errors in the DNA aren't getting fixed.
And these errors accumulate over time.
They do. And this is where we see the physical transition. We see regenerative nodules, which are benign attempts at healing, start to change. They become dysplastic nodules.
Dysplastic meaning bad growth.
Right. They start looking weird under the microscope. The cells are bigger. The nuclei are darker. They aren't quite cancer yet. They are pre-malignant. But they aren't normal liver anymore. They are precursors.
On the edge.
On the edge. And finally, one of those dysplastic nodules acquires enough mutations to survive on its own, ignore the body's signals, and invade. That is the moment of transformation into malignancy, as the birth of the carcinoma.
It is terrifyingly logical. It's not just bad luck. It's a mechanical consequence of the injury.
It is the biological cost of survival. The liver is trying to survive the damage, but the mechanism of survival becomes the architect of its destruction.
So we've got this malignant transformation happening. If we were to open up the body or look at a CT scan, what does this enemy actually look like? The outline mentions gross morphology, which is just a fancy way of saying what it looks like to the naked eye.
Right. When we look at the liver grossly, HCC typically follows one of 3 classic patterns. And visualizing these helps understand why it's so hard to treat.
Let's walk through them. Pattern number 1.
Unifocal. This is a single dominant mass, just one big tumor in the liver. It might be huge, but it's contained in one spot. This is often what we hope for, relatively speaking, because if the liver function is preserved in the rest of the organ, you might be able to cut it out.
Okay, that seems the most straightforward. Manageable, maybe? What's pattern number 2?
Multifocal. This is where you see multiple nodules scattered throughout the liver. Now, I want you to pause and think about why this is particularly tricky in a cirrhotic liver.
Well, if the liver is already cirrhotic, we said cirrhosis is basically a liver full of bumpy nodules, right? The regenerative nodules.
Exactly. In a cirrhotic liver, the whole organ is full of regenerative bumps. If the cancer presents as multifocal nodules, it can blend in perfectly with the background cirrhosis. It's camouflage.
So you have bad nodules hiding in a forest of somewhat bad nodules.
Correct. This makes detection incredibly difficult on an ultrasound or a CT scan. You have to look for subtle differences in size or how it takes up contrast dye, how the blood flow looks. You're looking for the imposters hiding among the crowd.
It's finding a needle in a stack of needles.
It's a great analogy. It's a nightmare for the radiologist.
Yep.
And the third pattern.
The third pattern.
The diffuse infiltrative pattern. This is arguably the most insidious. The tumor doesn't form a distinct ball or nodule. Instead, it spreads through large areas of the liver, almost like a liquid soaking into a sponge.
So it's not a lump, it's a takeover.
A stealthy takeover. It permeates the organ, often involving the entire liver, blending in so well that you might not even realize there's a distinct mass until the whole liver fails. It makes surgical resection impossible. You can't cut out a sponge.
Now let's zoom in even further. We take a biopsy, we put it under the microscope. What are we seeing at the cellular level?
We are seeing cells that are having an identity crisis. The tumor cells look like hepatocytes. They look like liver cells, but they are arranged strangely. The architecture is all wrong. They've forgotten how to build a proper liver.
What kind of patterns are we talking about?
Pathologists describe a few key patterns. There is the trabecular pattern. Normal liver cells are arranged in thin plates, maybe 1 or 2 cells thick.
Okay.
In cancer, these plates or trabeculae thicken. They become 3, 4, 10 cells thick. It's like a wall that's been built too thick and unstable.
And the notes mention pseudoacinar. What does that mean?
Yes. So acinar refers to a gland-like structure. The tumor cells try to form little circles with a hole in the middle, mimicking a gland. But it's fake, hence pseudo. They are trying to organize themselves, but they've lost the blueprint. It's a failed attempt at making structure.
Is there a smoking gun? Something that tells the pathologist, okay, this is definitely liver cancer and not cancer that spread from the colon or the lung.
Yes. The smoking gun is bile.
Bile.
Remember, the primary job of a liver cell is to produce bile to help digest fats. Even when these cells turn malignant, they often remember their heritage. You may see bile production within the tumor cells.
Wow.
If you see that green pigment under the microscope, it confirms their origin. They are hepatocellular. They are liver cells gone bad.
That's fascinating. Even in their rebellion, they're still trying to do their day job.
In a twisted way, yes. It proves they haven't completely lost their differentiation, but they're using it in a disorganized, malignant way. It's a key diagnostic feature.
So we have a tumor that hides well, mimics the tissue it destroys, and sometimes even produces bile. But the source material highlights that HCC is particularly feared because of how it spreads. It's aggressive.
It is. And there is one specific behavior of HCC that makes it truly dangerous. It has a strong predilection for vascular invasion.
It invades the blood vessels.
Very early in the disease process.
So,
And it has a specific target, the portal vein.
we should clarify the anatomy here. The portal vein is the main highway into the liver, right? It brings all the blood from the gut.
Correct. It brings nutrient-rich blood from the intestines to the liver for processing. It's a huge, low-pressure vessel. And HCC loves to grow into this vein. It forms a tumor thrombus, a physical plug of cancer cells growing inside the vessel.
Now think about the consequences of that. If you block the main highway, traffic jams.
Massive traffic jams. We call it portal hypertension. If the tumor blocks the portal vein, the pressure in the system behind it skyrockets. This worsens all the complications of cirrhosis.
How so?
Well, that high pressure forces fluid to leak out of the vessels and into the abdomen. That's ascites. The pressure also backs up into the veins of the esophagus, causing them to swell up like balloons varices, which can burst and cause catastrophic bleeding.
So the tumor acts like a dam, causing a flood upstream.
Exactly. But there's another, even more sinister consequence. By invading the vein, the tumor uses the blood flow to spread rapidly within the liver itself.
It uses the highway to colonize the rest of the city.
Intrahepatic spread. Exactly. Because the portal vein branches out into the whole liver, if the tumor gets into the main trunk, it can shower the rest of the liver with cancer cells. This is why you often see that multifocal pattern we discussed. It might start as one spot, invade a vessel, and spread everywhere.
And what about leaving the liver? Metastasis to the rest of the body.
Once it's in the blood hematogenous spread, it can go anywhere. The lungs are a common destination, as are bones. But uniquely, the drama usually plays out locally, within the abdomen, because of that portal vein invasion and the liver failure it causes. Patients often succumb to the liver failure or the bleeding before the distant metastases become the main problem.
This brings us to the patient, the human side of this pathology. We've got this biological disaster unfolding inside. How does it present? What does the patient actually feel?
The general symptoms are somewhat nonspecific initially. Weight loss, anorexia, loss of appetite, abdominal pain, or a feeling of fullness.
Which, to be fair, could be a lot of things. That could be indigestion or stress or just getting older.
True. That's why it's so often missed early on. Physical signs might include liver enlargement, which a doctor might feel, or jaundice, the yellowing of the skin and eyes. There's a high-yield clinical clue, a specific scenario that every medical professional, and really anyone listening who cares about this, should be aware of.
What is that scenario?
The sudden deterioration of a stable cirrhotic patient.
Paint the picture for us.
Imagine a patient who has known cirrhosis. Maybe from alcohol, maybe hepatitis C. They have been managing it for years. They take their meds, they watch their diet, they're stable, their labs are okay, and then suddenly they crash. They get rapidly worse for no obvious reason.
What does worse look like in this context?
A rapid increase in ascites fluid building up in the abdomen. They might go from having a flat belly to looking 9 months pregnant in a matter of weeks despite no change in their diet or medication.
And the notes mention something specific about that fluid.
Bloody ascites. Normally, ascites fluid is clear or straw-colored. If you tap that fluid with a needle and it comes out bloody, it suggests the tumor has eroded a blood vessel or ruptured into the abdominal cavity. That is a very ominous sign.
And other signs of the crash.
Sudden decompensation. This could mean sudden bleeding from varices, those dilated veins in the esophagus, because the tumor blocked the portal vein and spiked the pressure. Or a sudden encephalopathy, where toxins build up and affect the brain, causing confusion because the liver has been replaced by tumor and can't filter the blood anymore.
So the rule is, if a stable patient with liver scarring suddenly falls off a cliff health-wise, you don't just assume their cirrhosis got worse naturally.
No, you have to assume it's cancer until proven otherwise. You must rule out HCC immediately. That sudden change is the hallmark. It's the red flag waving in the wind.
It's a race against time at that point.
It is. And sadly, by the time these symptoms appear, the disease is often advanced. This is why screening for cirrhotic patients doing ultrasounds every 6 months is so standard. We are trying to catch it before the sudden crash.
Okay, let's take a breath. We've covered a lot of ground here. We've gone from the molecular level DNA integration of Hep B, P53 mutations, from mold up to the microscopic patterns, and finally to the clinical emergency.
We have. It's a complex disease, but understanding the story makes it stick.
Let's try to synthesize this. If we look back at the mission of this deep dive, it was to understand the path from chronic injury to cancer. If you had to distill this into the key takeaways for someone to hold on to, what are they?
First, remember the soil and seed. HCC rarely grows in a healthy liver. It is a disease of cirrhosis. The constant irritation from viruses, alcohol, or metabolic toxins creates a pressure cooker environment.
And that pressure cooker forces regeneration.
Right. That's the second key. Regeneration is the driver. The liver tries to heal, but the scarring and the inflammation create a chaotic environment. Eventually, the DNA snaps. A regenerative nodule becomes a dysplastic nodule, and then a carcinoma.
And visually, we remember the camouflage.
The multifocal pattern. The tumor hiding among the cirrhotic nodules. And the mechanism of aggression. Vascular invasion. The tumor attacking the portal vein, blocking the flow, and using the blood to spread itself inside the liver.
It's a tragic irony, isn't it? The liver takes years of abuse, viral, chemical, metabolic, the dispo, and it fights back every single day. It keeps regenerating. It refuses to quit. But there is a biological cost.
That is the thought I want to leave everyone with, the concept of biological cost. We tend to think of healing as a purely positive force. But in biology, nothing is free. Regeneration is a survival mechanism, but when you push a survival mechanism beyond its limits, when you force it to run a marathon at a sprint pace for decades, it breaks.
And in this case, it doesn't just break down, it transforms into something malignant. It becomes the architect of our own destruction.
Exactly. The very cells trying to save the organ eventually destroy it. And that is why early detection and managing those risk factors, treating the Hep C, controlling the alcohol, managing the metabolic syndrome is so critical. We have to stop the injury before the regeneration goes rogue.
Well, on that cheerful but incredibly important note, we are going to wrap up this deep dive into hepatocellular carcinoma.
It's a heavy topic, but understanding the mechanism is the only way to catch it early.
Absolutely. Thank you for walking us through the pathology. And to you, listening, thanks for diving deep with us. Keep questioning, keep learning, and we'll see you on the next one.